Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning into the Tate Chronicles. Join me as we cut to the fog that exists at the leading edge of healthcare technology. I'm really pleased. My guest today is none other than Steve Yaskin, the CEO of Health Gorilla. Health Gorilla is absolutely at the forefront of healthcare data interoperability, and they also recently received official designation as one of the initial Qualified Health Information Networks, the QHINs, that are supporting the TEFCA exchange for healthcare organizations nationwide. Steve, thanks for joining the Tate Chronicles today.
Thank you, Jim, for having me. Excited to be here.
I recently read a post of yours that was titled The 5 Interoperability Predictions for 2024. And I'd like to discuss those. So let me just kind of kick it off with one of the initial predictions you made, which is that the TEFCA QHIN ecosystem will, in 2024, we'll see an expansion as well as the maturing of that. So do you think the ball is really going to be rolling in 2024?
Yeah, no, sounds good. Again, thanks for having me. We decided to do our own predictions. It has become latest industry trend to predict what's going to happen in the upcoming year. And then, as it goes, follow up at the end of the year and see if any of this became true and anything did not. So we did put out 5 predictions of our own. And one of the first ones, as you mentioned, Jim, was the expansion and maturation of the QHIN ecosystem. And it's kind of easy to make that prediction because it did not happen in December. QHINs did not start in December. We just went live in December, but there was tremendous amount of work that had been happening over the years. We had a lot of people congratulating us in December when we got designated for Qualified Health Information Network with the federal government. But it's been a couple of years in the making. And we got just on the start line, and we are off to the races. There's been a tremendous amount of work, investments, time. It is a partnership between the federal government and the private sector. And because of that buildup that took place over the years, relentless work by the ONC, RCE, and the federal government, as well as participation of private companies, so the 5 original initial QHINs that got designated, it leaves very little doubt that the QHIN ecosystem will continue to expand and become a lot more mature and bring a lot more innovations according to the roadmap that we put out there.
One thing you mentioned a couple of times was the word years. That's right. The federal regulations and legislation that created TEFCA, I don't know exactly, but I believe it goes back at least 6 years. So this has been a long time coming. Yeah,
it all started with the Cures Act. It was passed during the Obama's administration with bipartisan support. If I can mention that, this is how you know it was a long time ago. It was an act of Congress that actually received full bipartisan support, and it has been years until finally it culminated in the TEFCA going live in December of 2023.
One of the things, Steve, about TEFCA, and our audience is certainly up to date on most of the concepts around TEFCA, but let me just give you my 30-second view on it.
Sure.
TEFCA is a network for the exchange of health information data. And what we hope is that it is like maybe the U.S. phone systems. It doesn't matter what phone I have or who my phone provider service is. I can pick up a phone and call you no matter where you are. It doesn't matter anything else as far as what kind of phone or who we pay our monthly bill to. Your phone's going to ring and we can talk. And so there's a lot of handshaking and agreements, and I guess that's part of TEFCA. It took years to get those agreements between as a basis for organizations to say, okay, yeah, we will buy into this common agreement. That seems to be in place now. Now, I know over time that those agreements are going to change, or certainly from a technical standpoint, as standards like fire come into place, things like that. But the concept that anybody any provider who is connected to any of the QHINs is really connected to all the QHINs, and can do an inquiry and get a response. So that leads me really to the second prediction: is to providers, how are they going to be incentivized by perhaps the federal government to participate in the TEFCA network?
Yeah, sounds good. This one was obviously also somewhat easy to make that prediction that we will see additional federal proposals coming down the line to incentivize TEFCA participation. TEFCA, when it went live in December of 2023, remains voluntarily participation. But let me outline what TEFCA means, right? As you mentioned, Jim, there's been a lot of local agreements. There's been a lot of contracting done. There's been a lot of variations on various, data rights and how we exchange data in this country for, past 10 plus years. And there's been a lot of handshakes done in the industry. The industry needs to interoperate with the advances of value-based care. There's a lot of incentives out there in the market on both sides, on the public and the private side, to create data exchange. It is increasingly becoming all about data. Providers need data, payers need data. The whole ecosystem needs data to operate and provide value into various financial arrangements and to provide better outcomes while reducing costs. And physician burnout is one of the big problems that TEFCA is designed to solve. But the difference here is that it was created uniquely so as a partnership between the public and the private sector. That kind of what sets TEFCA apart from previous regulations that were passed down from the government. And the industry, let's be honest, had found many ways to check the box and not move the ball forward very much and become compliant with various regulations. And TEFCA is a culmination of all experiences that we had over the years with meaningful use, with various CMS incentives. And this time it was different. A lot of people ask me, why do you think TEFCA is different? We had so many different programs and incentives. And it is different because it actually designed to be a partnership between the public and the private sector. There's a lot of sticks and there's a lot of carrots out there to make sure TEFCA is successful. Let me remind you that TEFCA is two-part framework. One of them is the technical part, which is called QTF, Qualified Technical Framework, which kind of resets the floor on how we interoperate. And the second part is the common agreement. That's the TEFCA, the second part of it, which everybody has to sign on. All participants sign into the same common agreement, setting up kind of level playing field for everybody to participate. TEFCA also regulates a total of 6 permitted purposes. What kind of organizations can exchange data and gain access to that data? The one that we went live with, there are 2 permitted purposes of exchanging data, is treatment and individual access services, IAS, basically outlining that individual people can get their data the same way their providers can over the legacy networks, and now TEFCA is taking over. There are 4 more additional permitted uses to the TEFCA that are coming this year, over a period of this year, and that will be payment, operations, benefits determination, and then finally public health. TEFCA is also designed to meet the industry where industry is today at that given day. And we are coming out of the world of legacy exchanges that are gradually starting to be moving to the TEFCA rails. And the first two are treatment and individual access. And as we embark on the additional roadmap in partnership with the federal government, we are very excited to set up all 6 permitted purposes sometime in 24.
One of the things we're talking about right now for the second prediction is the really participation. How to incentivize participation or actual use of this data of the TEFCA networks. Years and years ago, to get the adoption of EHRs, the federal government essentially bought every provider in the country an EHR. And
Right.
then they, certainly on a provider basis, they paid the regional extension centers quite a bit of money to train providers to meaningfully use their EHRs. I don't see any certainly federal funding for any training in workflow use or process. Have you seen anything like that?
Well, again, we've ran so many different federal and state incentives here, like you said, to help provider organizations implement electronic technology like EHRs and EMRs. You mentioned meaningful use. There's been a lot of programs like that to incentivize, educate, train, help provider organizations to adopt technology. And we largely succeeded in that. To some estimates,
Yes.
there's about 100% of provider organizations use some sort of electronic health record system today. That remaining 30% of rural hospitals, rural ambulatory providers, where federal dollars did not make that much of an impact. And TEFCA is the final frontier, which is designed again to make it easier to adopt technology and exchange data. And it's all going to be about expansion and adoption right now as the
Yes.
legacy networks start to move on to the TEFCA rail, sign common agreements. As you know, there's pretty broad participation from day one, from December 12th of 23. Hundreds, if not thousands, of organizations already signed up, already started live exchanges on that date. In the morning of December 13th, we had live exchanges going on treatment and even consumer access. And it's going to continue to grow in 24 and 25. We will see a lot more regulations come down. We are armed already with some sticks, so to say. There's a data blocking provision out there, which, as you know, puts out like $1 million fine for proven data blocking.
Yes.
When consumers are unable to gain their own data. So it's a pretty big stick, but TEFCA also makes it a lot easier to actually comply. And in some cases, all you have to do is join a QHIN and kind of use your existing platform where you have data, whether it's EHR or any other provider organization or payer organization system. Join the QHIN and armed with common agreement and QTF compliance on the EHR vendor, we make it somewhat easier already today to be compliant and to respond both for treatment and for the consumer access. And joining a QHIN also ensures that you will stay compliant because more and more regulations are passed down for payments, operations, and then finally public health. And that's how TEFCA is designed, to make it easier, to make it adoptable. And we're very excited to see all 6 permitted purposes of exchange grow.
If you're just joining us, I'm Jim Tate, and on this episode of the Tate Chronicles, I'm speaking with Steve Yaskin of Health Gorilla, and we're talking about predictions concerning interoperability in 2024. One of the things, Steve, you mentioned is individual access services. So we know that providers will be connecting to a QHIN and through the other QHINs to the TEFCA platform. If I'm an individual and I just want access to my data, how will I do that? Will I do it through some third-party app, or can I connect directly to a QHIN?
Either way, You
Really?
should be covered.
Yeah.
TEFCA is designed, and QHINs are absolutely designed not to be the bottleneck, not to be the sole provider of access points. In fact, we as QHINs have to, by law, by regulations, provide easy access, vetted, but easy access to any app out there that wants to create value to consumers. As data access becoming commoditized through TEFCA over the next couple of years, it's going to be about the value proposition. Think about Credit Karma, right? It is connected to credit bureaus, which contain and store your credit financial data. And they build on top of that data set to expose additional values that consumers sign up for. Very similar in that case, QHINs are designed to make it easier to connect, verify compliance. We have IL2 type of biometrical verification for the consumers. Some QHINs offer that out of the box, like Health Gorilla does. Some QHINs ask the apps connecting to them for the consumer access to have that step and verify that later. And it is really up to consumers to pick the app they want. And that app, if they belong, if they're a member of one of the QHINs, should be really easy to consume this data. And more importantly, there's a great focus on making that data actionable. We don't want just to dump a bunch of garbage, right?
Exactly.
And this is what was plaguing all the legacy networks for years. Garbage in, garbage out. So the focus absolutely was meant to meet the industry where the industry is today. You know, there's a lot of old mechanisms of exchanging data. HL7, all versions. We see a lot of V2, which is really old tech. We see a lot of CCDA. We see a lot of document exchanges. All legacy networks are built on document exchanges. What that means is if you match the consumer, you connect, you query, you get hundreds of thousands, maybe documents, hundreds or thousands of documents for that consumer just dumped on you. And it's really hard to make sense of that data, both on the provider side and on the consumer side. And we have FHIR absolutely on the roadmap for 24, which allows for things like bulk querying, like very specific querying based on a condition, based on allergy. All the PAMI data is coming into play in a very much structured and clean way. But it is a lot of work. We've accumulated tons of data over the last 10, 15 years since EHR technology started to become prevalent. In healthcare, we have to clean up the mountains of data that's been accumulated and ensure that going forward, we will start exchanging data in FHIR and paying a lot of attention to how the data is stored, processed, and transmitted. There's a lot of attention to taxonomy of the data, ontology of the data, and a lot of governance on the data, right? It's no secret that what is considered healthcare in one state, you go across the street and it's you're probably violating some data exchange laws, right? I'm talking about SADS data, substance abuse data. I'm talking about behavioral data. I'm talking about reproductive data. There's a lot of different regulations out there, and just exchanging data across the country sometimes could be violating certain states. And QHINs are in a very unique position to drive that forward, make exchange trusted. Remember, the first letter in TEFCA is trusted. And this is what QHINs and TEFCA role is designed to do, is to bring that trust back so that providers exchanging data with payers, everybody exchanging data with consumers have somebody to rely on, and we bring that trust into the clinical data exchange.
We only have about 5 or 6 more minutes here, Steve, and I want to make sure we get to our last two predictions. One of the ones is that 2024 will see a strengthened synergy really between regional and national data exchange. So has that been an issue up to this point? The data is kind of regionalized, but is not available on a national level? Has that been a problem?
Yeah, there's a lot of debate going on in the country today, starting from individual health systems that sometimes deploy like more than a dozen different EHRs that don't really talk to each other, going to the county level, going to the state level, with lots and lots of bespoke local contracts, right? So we're talking about state-driven HAEs and RIOs, as they're called, regional data exchanges. They still today hold a lot of local contracts with provider organizations and payers, and there's a lot of state regulations that require the entire state or local regional ecosystem to submit data to HAEs. They're still operational. A lot of them didn't make it. A lot of them are healthy. We see a lot of examples of funding in states, and we see a lot of examples where that funding did not come through, and a lot of state exchanges shut down over the last couple of years.
Yeah.
TEFCA is designed as a federal highway, right? Think about like I-95 going across the country, south to north and east to west. And HAE state connectivity centers play a pretty big role in that. Those are the on-ramps onto the interstate freeway. And a lot of them are ready to join us. One of the QHINs, as you know, is the Health Exchange, which has a lot of that local connectivity. A lot of state-driven HAEs participate in the Health Exchange. But a lot of them are not ready yet because of the limitations they have with the local contracts. So there's still a fair amount of work ahead of us on creating those synergies between local exchanges and helping them to join federal interstate, which is TEFCA. That's where we're going to be focusing over the next 2 years as well.
Yeah. Well, that brings us to prediction number 5, which is really intriguing to me, Steve, that the first real AI use cases will emerge from QHIN participants. What do you mean by that?
Yeah, there's a lot of hype about the usability of AI in the clinical world. And you have to overlay that with the fact that healthcare is probably 10, maybe even more years behind all other industries where AI is making pretty good forays in automating a lot of processes, making it really easy to adopt AI and actually has a lot of value. Healthcare is probably a decade behind everybody else. So before we can start talking about meaningful usability of AI in healthcare, we have to make sure we train AI properly. Majority of all other industries have trained ML, machine learning, and emerging AI use cases on clean data. We don't have that still, and this is one of the big outcomes of TEFCA is to create a national set of clean, usable, actionable clinical data that, as one of the outcomes, could be used to train machines and therefore finally create a meaningful adoption of AI. If I'm honest, we're probably still a year or more away from individual use cases. What you see out there is a little bit of hype surrounding, individual health systems training AI on their local data.
Correct.
But it has a lot of gaps. You need to be training on the complete patient-centric data set using US CDI standards on which TEFCA is based and using a fuller data set. If you train AI on a subset that you have access to, it's almost make it less relevant and somewhat dangerous to train on that kind of data. AI has a huge role here. Like I said, we have mountains of data to be processed, standardized, fit into US CDI taxonomy and ontology. This is what we're doing as QHINs. Health Gorilla is already using AI internally to allow us to better match patients nationally, to clean up the data, remove duplicates in the data. There's a lot of data quality activities that within Health Gorilla that we're utilizing from that perspective. But I think TEFCA is going to be the platform to be able to bring AI into healthcare.
No, that makes perfect sense. But before we say goodbye to our listeners, Steve, if they want to find out more about the services offered by Health Gorilla, not only QHIN and TEFCA access, but all the different services, where should they go to find out more information?
I have to mention the recognized coordinating entity, RCE.
Yes.
Go on the Office of National Coordinator of Health, ONC, website. It is part of HHS on the federal level, and there's a wealth of information there. If you want to learn about how Health Gorilla QHIN, Qualified Health Information Network, is different from other QHINs, we all created very differently. Health Gorilla was created years ago as a QHIN before we even had a federal regulation. So we are not based on any specific EHR. We're not dependent on the state funding. We are created just to serve TEFCA. So we have tremendous amount of information, educational purposes, and explaining what TEFCA QHINs are and what we're doing to execute on the roadmap to build interstate freeway of information for healthcare. You can head to the healthgorilla.com website and watch webinars. We have a lot of webinars and white papers, and hopefully this recording we're making right now will serve the same purpose.
Well, to our audience, thanks for joining me on this episode of the Tate Chronicles. Of course, I offer a special salute to my guest today, Steve Yaskin of Health Gorilla. Steve, thanks for coming aboard today.
Thanks for having me.
You can find more information on this show's program page at healthcarenowradio.com. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.